to the findings from the Safeguarding Adult Review TAO. It's also really nice to see some familiar names popping up. Some of you I've met directly, some of you I worked with for many years. So, but that was a long time ago. So I'm just going to go through the findings from the review. I'm trying to make the next 2 hours an interactive and reflective session, really. So the way I'm going to try and do that with the wonders of technology is to use some breakout rooms a couple of times for us just to have a kind of pause in the journey and thinking about the experience as we go through 3 key episodes of care relating to TAO. And I'm going to have stop points as I talk through those episodes of care, really, and just ask us all to do a bit of reflection on what was TAO's experience, what was the experience of his mum, what do you think were the kind of key points in terms of quality standards that you would expect to see in relation to those episodes of care. And then we're going to have a coffee break, probably around about 3:15. And when I come back, we'll talk about what the actual findings were from the review. So hopefully that will work. It'll give you a chance to have a bit of reflection, a bit of discussion, and really just kind of time to hopefully take in some of the learning points as well. So just to start, the review relates to TAO. That is his actual name. That was at the request of his mum. She wanted his name to be used in this review. Really sadly, TAO died in October 2020, and he ended by his life having been fatally injured on the train line just outside of Kettering train station. TAO had quite a long history of mental illness, and he'd been discharged from a period of inpatient care 2 weeks earlier. So just really to reiterate what Chloe was saying, the purpose of Safeguarding Adult Reviews is very much about exploring learning. It's about identifying the things that worked well. It's about identifying things that could have been done better. And it's really about also understanding the systems that surround how practitioners work together, and looking at any barriers to people doing the best job that they're able to do in times when we know resources are very, very stretched. So in relation to TAO, the review looked at the last 2 months of TAO's life. And at that time in his life, the key people that were there for TAO was TAO's mum. She was his primary carer. She lived with him. They shared a house of multiple occupancies, I'll discuss. He'd had quite a lot of involvement with his GP. He was well known to his GP over the past years. He'd had involvement from NHFT, Northamptonshire Healthcare Foundation Trust, both through their early intervention service historically, and more recently through their recovery team, their longer term team, but also in terms of their urgent care and assessment team. He had some involvement from social care, mostly through the Approved Mental Health Professionals Service. British Transport Police, as we go through his story, I'll talk to you a bit more about that. Ambulance service had been involved, Kettering General Hospital, and St Matthew's Inpatient Care, which is our private mental health provider based within Northamptonshire. So I thought it's necessary really to set some of the context around understanding the events surrounding TAO. So we know that suicide is a major cause of death among people with a diagnosis of schizophrenia. Very sadly, mental illness is one of the primary vulnerabilities for people who end their life by suicide. Whilst risk factors may be known, so there's lots of risk factors where researchers identified risks that surround that are known to be prevalent leading up to people ending their lives by suicide. But thankfully, many people who have those risk factors won't necessarily go on and end their lives by suicide. And it can be incredibly challenging recognising the factors that make the difference, really, of when somebody who may end up going on to die by suicide and those who may also carry risk factors, but for whatever reason don't end up dying by suicide. And the reason it's important to point that out is we have to be really cautious about avoiding hindsight bias. As independent author, I've got the added knowledge of knowing the outcome of results and being able to look back retrospectively and look at factors that are now known but weren't necessarily all known or were all known in one place. So it was about trying to be measured and understand what was known at the time and what was reasonably possible to understand around decision making, etc., at the time that those events happened. It's also important to recognise that this event happened in the first year of the pandemic, and I guess all of you are well aware of the challenges that presented, both in terms of having consistency of staff, but also the pressures that staff were under. So the main body of the report, the first section of that talks about understanding and using learning from research about understanding risk factors in suicide. And I guess you could loosely group them under three areas. So there's risk factors that are associated with somebody's illness. So those are having that diagnosis of schizophrenia. It also includes use of alcohol and drugs. It includes where people might have an acute episode of illness, where they may have insight into their illness but have a real fear about deterioration or having lost faith in the treatment for their illness. It includes the use of medication and being concordant with medication as prescribed. And it includes having previous history of self-harming behaviour and thoughts of suicide and acting on those thoughts in the past. So there's a whole collection of risk factors and warning signs that surround having an illness, a mental illness. There's also a number of psychological and social factors which kind of cluster together. So those are things that, you know, would affect everybody's mental health. So having stable housing, having employment, having secure social relationships, being supported, being married, having a network of friends. But also psychological aspects like having recently had bereavement, undergoing loss, having family members who have died by suicide. All of those factors, again, cluster together around those kind of psychological and social factors. And then thirdly, we know that there are also time and place factors. So we know there are high risk times when people are at heightened risk of suicide. And those times might be when somebody's in patient care or just at point of discharge from psychiatric care. We know that certain times where, for example, anniversaries of people's birthdays, people's deaths, those periods can give heightened risk. Christmas can be a heightened risk for many people. And there are also locations of risk. So we know from Public Health England that very sadly there's certain places where people may use to end their lives. So high bridges, train lines, those kinds of places where people may go and contemplate suicide. So we know that there's locations of higher risk as well. So the job for all of us is about understanding those risk factors and bringing those all together and using them to inform risk assessment and making sure that's a dynamic risk assessment. So that's the context that we're working in. And I guess the other thing that's really clear from research is that this is a complicated business. It's complex to be able to accurately predict. It's not possible actually to accurately predict where somebody may well die by suicide. So the National Confidential Inquiry to Suicide and Safety, it used to be called Suicide and Homicide, developed these key elements for safer care for patients. And you can see them on the screen there. I'm not going to go through all of them because you've got that information there, but it's really key about how services are configured, making sure that people are admitted to hospital closer to home so they can keep that social connectivity, having 24-hour crisis teams follow up when people are discharged from hospital, and having consistency of care. Those, amongst others, are kind of key factors that help to keep people safe and reduce the risk of suicide. So I'm going to move on now and just apply that to thinking about Teo and Teo's story. So he was a man, he was in his early 20s. He lived with his mum in a house of multiple occupancy. He and his mum had moved to the UK from Europe some years earlier. And this had followed his parents' divorce. Teo found that divorce really difficult, and around about the age of 15, 16, he began using drugs. So he was using cannabis to quite a high degree. Teo's father had also had schizophrenia, and he used to talk to Teo about his illness and his experience of his illness. Teo's own mental health problems began when he was about 16 years old, and he began experiencing symptoms of psychosis. And at that point, he was supported through the early intervention psychosis service. He did engage quite well with that service. He talked occasionally about having thoughts of self-harm and thoughts of suicide, but there was no active planning around that, and there was no following through on that plan in terms of self-harm. Very sadly, Teo's father died in 2019. What we know now is that Teo believed his father died by suicide. It's worth noting that his mum doesn't think his father did die by suicide. So we're not clear. We're not clear whether or not there was an inquest or what the outcome. But I guess the important thing is Teo's belief was his father died by suicide. And if you remember the earlier slides, that in itself is a risk factor. Teo's mental health deteriorated in the period following his father's death. We don't know if it was directly attributable to that or not, but we know his mental health did deteriorate. And he had a brief admission to psychiatric inpatient care at that time. He found living in the house of multiple occupancy difficult. His often behaviours would be he would leave the house, he would go off walking on his own and like to spend periods of time on his own. He wasn't working since 2019, so there was very limited structure in terms of the support to his life. And there's very little we know also about his network of friends. His mum was a key person who used to look out for him. So the review's written around 3 episodes of care. So in 2020, this is leading up to the first episode of care, so his pre-admission phase. Teo's care, because he was older then and his mental health needs were more known, he was transferred from the early intervention psychosis service to the longer term recovery team service within NHFT. He had a new care coordinator appointed at that time, and at that time there was a good period of handover between the NSAB team, the early intervention team, and his new team, the recovery team. However, very sadly, soon after, Teo's mental health deteriorated again. His mum alerted services. She was very worried about his mental health. And the care coordinator in his new team spoke with his previous care coordinator, and they agreed a joint visit to go and see him. And when they went out, they felt that Teo was becoming quite acutely unwell. There was concerns about his use of medication. And at that point, they felt, because Teo wasn't willing to contemplate going into hospital, they felt an assessment under the Mental Health Act was required. So they alerted the approved mental health professionals and set about coordinating his assessment. Unfortunately, although there was concerns about Teo on that day, the services weren't able to get the necessary doctors together to go out to complete the assessment on the day. So they worked with the police, notifying the police and with the ambulance service to arrange for the assessment to happen the following day. When that assessment occurred, Teo was detained under Section 2 of the Mental Health Act, and that's a section for a short-term assessment followed by treatment. At that time, and you remember this was right in the middle of the COVID period, there was no beds available within the Northamptonshire Healthcare Foundation Trust. And so they arranged for Teo to be admitted to St Matthew's Healthcare, and that was within Northamptonshire. You might know it's just out in the country. So I'm just going to pause for a second there. We're not going to break out just yet, but I'm just going to pause and get you to think about what's in your head at the moment about what was happening for Teo, what was happening for his mum, what standards of care would you expect to see, and what do you think you would have liked to see? What were the areas of learning? Just get you to think about that for a second, and then we're going to move on to episode 2. Does anyone have any questions or observations at this point? You can stick messages in the chat if anybody's got anything that's popping into your heads at the moment. Okay. So Theo was assessed at that point and he was admitted. And when he was admitted, he talked to the psychiatrist who was doing the admission assessment, and he talked to him about his illness. And during that time, he talked to the psychiatrist about his father having died by suicide. And he appeared to be quite kind of a flat in terms of how he described that. He was viewed as being at some risk of self-harm and suicide, but that was really because he talked about his experience of his illness at that time, and that sometimes he'd just feel like banging his head on the wall. He was clearly very distressed by his experience of the symptoms. As part of his admission process, he was screened for use of drugs, and the screen came back as a negative drug screen. And at that point of admission, Theo was also registered with the GP who was linked with St Matthew's. And that was the practice of St Matthew's at that time, was just to register everybody who was admitted with their in-house GP. Because of COVID, Theo's mum wasn't able to visit the ward. She wasn't allowed to visit the ward. They were obviously trying to keep the numbers of external visitors down as part of the safety planning around COVID. And the staff at St Matthew's tried to keep Theo's mum involved, tried to phone her. I think because Theo's mum was working different shift patterns, sometimes being able to contact her was difficult. Theo's mum would say that she found the communication with St Matthew's difficult and felt that sometimes her messages asking to speak to the doctor weren't always getting through. However, during the next 3 weeks, Theo's mental health responded to treatment. He started to make a good recovery. They reviewed the medication regime that he was on, increased different aspects of his medication, and began planning for his discharge. During this inpatient period, NHFT had arranged for their bed manager to be the single point of contact in terms of tracking the improvement for patients, looking at when the patient was ready to be discharged, and liaising with the care coordinator who was back out in the recovery team. So Theo's care coordinator didn't have direct in-reach communication with Theo, but they kept track of his progress through being informed by the NHFT bed manager. So Theo's mental health improved, and the section 2, so the detaining section, was rescinded. It was lifted. Theo remained in hospital for 2 or 3 days whilst and the discharge plan was firmed up. And the nature of this discharge plan you can see on the screen there. So Theo was to be discharged with enough medication so that he had enough to keep going until it was set up through his GP and through his pharmacy. They'd arranged with the urgent care and assessment team for them to have immediate follow-up. I think Theo was discharged, I think, on a Thursday by memory, and the urgent care and assessment team were going to do a follow-up within 48 hours. There was a referral for occupational therapy, and that would be provided through the recovery team. And that was really recognising that Theo's may benefit from more kind of purposeful activity and helping him to really have more of a structure to his day. His care would be supported by ongoing support through his care coordinator from the recovery team. The plan was for Theo to be re-registered back with his GP, who he had been deregistered from at point of admission, and then the discharge summary would be sent to the GP and to PCART. So just to give you a break from hearing me droning on, I'm now going to ask, and we're going to test Chloe's skills in terms of trying to shift you into your rooms to do a bit of discussion really on what you've heard so far. So I'm going to give you, I'm just checking my timings at the moment. I'm going to give you just under 10 minutes to be in your rooms. You're going to be in a room with probably about 7 or 8 people in the room. And I just want you to think about those first 2 episodes of care. So what are your reflections that you might have on those episodes of care? So the period leading up to Teal being assessed, and also that immediate inpatient care. What standards of care would you expect to see? So from your own knowledge of what should happen, what would you want to see? What do you think Teal's experiences were? So if you were standing in Teal's shoes or in his mum's shoes, what would be the things that would be concerning you? And anything that you see which was good practice in any areas of learning. I'm not going to take death by feedback when we come back, but if people are happy to put a few messages in the chat room or to put up your hand if you want to discuss anything, then that's fine. So if I can get you to move into or you will be moved into your groups. You've got just under 10 minutes, and then we'll bring you back and just pull out some of the key points. Thank you. Oh, this is scary. That actually worked, didn't it? The wonders of technology. Fabulous. Chloe, have we got all the rooms back in now?
I think so. I think they're all closed, yeah.
Fabulous. Thank you. Okay. So, as I said, I'm not going to do death by feedback, but does anybody want to add anything into the chat room that they particularly observed or kind of struck them in terms of that bit of reflection? Is there anything that people wanted to think about what were the kind of key points of that point of admission or the assessment process leading up to it? Thinking about what Teal's experience might have been or his mum's experience. Okay, we will move on. So I'm going to try and share my screen again. Okay, is that up on screen now?
It is. Sylvia, you do have 2 comments in the chat now if you want to.
Thank you. So what I'm seeing in the chat was Irene talked a lot about lack of identity and context. Thank you, Kim. And Jane's also saying there could have been trauma associated with father's death and migration, which was not explored. Absolutely. So I think that some of the factors when you think about people living with illness, living in a house of multiple occupancy, and then also trying to deal with those what potentially are really difficult issues for people to deal with in terms of, his identity as he moves forward as a young man in his 20s. He's living with his mum coming to terms with him maturing as an adult, wanting to live and be more independent, and alongside all that, coming to a relatively new community and making those sorts of adjustments. I'm just going to put my mic on hold for a minute with somebody. Sorry if you could hear my dog barking in the background. Hopefully he's being sorted. Okay, so moving on to now looking at care episode 3. So this is particularly looking at the post-discharge period. So Teal's mum was had contact from the ward, talking to her about planning for Teal's discharge. The day after he was discharged, she contacted his care coordinator to say that she was worried as Teal had been staying out overnight. So basically he'd been discharged and the same day he disappeared off. He wanted space, which again, if you think about Teal's experience of having been in inpatient care, where he was fairly contained within the ward environment because of the physical proximity from being far away from everywhere else. And he would want some space, but his mum was concerned about him. The care coordinator at this point was about to go on leave and told Teal's mum that they were going to be on leave. The care coordinator passed mum's concerns on to the urgent care and assessment team, the UCAT team, and noted also, told that care and assessment team that they were due to go on leave. So the care and assessment team visited, and that was within the 48 hours post-discharge period. Theo didn't want to speak to them. He was on making his way outside of the house. He was on his way out. The people who were working within the team kind of tried to engage him, tried to have a chat with him, talk to him about how he was feeling. He didn't really want to talk to them at all. His mum was there and he was just reluctant to engage. His mum, however, did chat to the urgent care team and said she was worried about him. She didn't feel he was himself. She was worried because he wasn't really talking to her. He was just wanting to leave the house and be on his own all the time. And she wasn't sure about how he was taking his medication. The UCAT team tried to reassure her and told her that the care coordinator would be in contact the following day. So this visit was happening at the weekend. From memory, I think it was a Sunday, and they said, oh, don't worry, your care coordinator will be in contact with you the following day. Well, of course, that was incorrect. The care coordinator was off on leave. The care coordinator had given mum a contact number and contact routes to contact whilst they were away. But mum texted the care coordinator and texted the care coordinator on their work phone and told the care coordinator about their concerns. The text went unread because the care coordinator was on leave. The GP, another key person in their care plan, wasn't aware of any of the circumstances that had led up to Theo's admission or hadn't received a discharge plan and wasn't really aware of what the plans were because that information had gone to, when they looked on the system to see who was Theo's GP, well, he was still registered with the GP who was based at St Matthew's Healthcare. A few days later, the Theo was found next to the train line. The train driver had seen him next to the train line, had been next to the train line, had been very worried about him and had contacted the British Transport Police. They spoke with Theo. They also spoke with Theo's mum, and they understood that Theo, from his mum, they understood that he had recently been discharged from psychiatric inpatient care, that he had a diagnosis of schizophrenia. So the British Transport Police at that point tried to contact the triage car, which is a car which is managed jointly by the police and Northamptonshire Healthcare Foundation Trust, so a mental health practitioner from the trust, who jointly work together to support people with concerns about their mental health within the community. So the Transport Police tried to contact them to find out a bit more and to also engage their services, but unfortunately they were already involved in another call. So the Transport Police took Theo to KGH, to the to the emergency department at KGH, and they spoke with a member of staff at KGH and told them what their concerns were, where Theo had been found. There is a bit of discrepancy in the recall from those two different services about what information and the detail of information that was shared at that point. But the member of staff at KGH spoke with Theo and asked him how he was. They asked him whether or not he had any suicidal thoughts, and Theo said, no, I'm fine, I just want to go home. He was offered to be seen by the mental health liaison service at that point, and Theo said, no, don't need it, I'm fine, I just want to go home. So the member of staff from KGH said to the police that in their view, Theo was okay to go home, so that the Transport Police took him back home. They did send a follow-up notification, and they sent a follow-up notification to 2 points. One was to Theo's GP and the other was Northamptonshire County Council, as it was then. Obviously it's not anymore, but they sent that through to the single point of contact, just explaining what the incident was, that they'd found Theo at the side of the railway line and had taken him to KGH. So the next day, Theo's mum phoned his GP and she was saying she was worried about him. The GP doesn't have any recall of Teo's mum telling him that the police had found Teo by the railway line, and at that point the GP hadn't received the notification from the British Transport Police. So they spoke to mum. They tried to reassure her. The GP spoke with Teo, and Teo said, he was fine and there was nothing wrong with him. So the GP tried to reassure mum. Later on that day, the GP practice had the notification from British Transport Police and uploaded it onto Teo's records. So there wasn't any proactive flagging of that information. It was simply, that information was simply placed on his records. Meanwhile, the NCC had received the notification and had looked to forward it on to Teo's GP. They felt that there wasn't any immediate action. It was fine just to notify the GP, which is what they did. There was some delay in that information getting through, so we think it took about 6 days for that information to go from the council to end up with the GP. Teo's care coordinator had returned from leave, and they looked at their work phone and they noted the text messages that Teo's mum had left. On the day that the care coordinator returned from leave, they were actually on a training day, so they weren't able to access the electronic records to read what had happened to Teo, and hadn't seen the notification that had come through from the GP to say that the British Transport Police had found Teo next to the railway track. So the care coordinator had phoned Teo's mum without the knowledge of what had happened, phoned Teo's mum to talk directly with her, to hear what had happened. And again, there is no recall that she'd said that the police had found him at the railway line. Teo's care coordinator reassured her and arranged for a follow-up visit in about a week's hence. Meanwhile, the GP practice received that second notification that had gone through NCC, and the person at the practice that had received it reviewed it. They sent a task, so that's a kind of a flagging system, if you like, on their electronic record to Teo's care coordinator, saying, have you seen this incident, and asking about what follow-up was planned. Teo's care coordinator didn't actually see that flag that had been sent. The following day, Teo left the house. His mum was concerned about how he was presenting. She was concerned about his mental health, that he seemed quite distracted. He'd also been talking to her in a way that she wasn't used to, so saying how much he loved her as a mum and that she'd been a good mum. So he was saying things which she felt were just different. He had said that he was going out to go and meet up with friends. His mum was concerned and contacted the recovery team, duty team, to try and speak to the care coordinator. Unfortunately, they weren't there right at that time, and the administrator said that they would get their duty worker to respond within 24 hours, which was within their response, their agreed response time. Very sadly, Teo did return to the train line that night, and he died by suicide, having been hit by that train. So I'm just going to open up for some thoughts and reflections, really. Whole group this time. We're not going to move into the small group rooms just yet. But I'd just like to get your thoughts really on what you see now, looking back over those 3 episodes and thinking about what I'd said at the beginning of this presentation about risk factors and warning signs. Does anybody just want to add into your chat room or stick your hand up to talk about what the risk factors and warning signs for suicide that you've observed as I've talked through those episodes? You don't need to know them all, you can just add some in. Okay, got a few coming in now. Thanks, Carlos. So Carlos has said, I've got mental illness, age, male, father suicide. Kim, has added on his own thoughts about his own dad dying by suicide, being found next to the train line, saying he's fine and not talking about his thoughts and feelings. Sarah, thank you. You said mum obviously picked up on the way that Teo was talking about professionals and didn't seem to act on that urgency. Lorna, you've observed that the way he was speaking differently to his mum. Absolutely, James reiterated that change of behaviour with mum. So mum being somebody who understands him well. Any other thoughts there? Bill, the fact that he'd been detained previously, yeah, so we know that he can become very unwell, and he'd recently been unwell indeed. Jane, relapse signature involves train tracks. Yeah, in terms of his previous admission, there hadn't been involvement in train tracks, but we know a week earlier he'd been there, so potentially thinking about contemplation. Him not knowing if he's taking his medication, absolutely not concordant with medication. Adriana's saying limited friendships, so he's socially isolated. Abby, thank you for that. His mental health, his dad's previous suicide, change in circumstances, his at home, his change in behaviour, withdrawal from support from services, previous section, absolutely. So there's lots of factors there. Thank you, everybody. I'm just going to bring us on to the next slide, and you've picked up many of those factors. So obviously, when we're looking at the understanding mental health, this biopsychosocial model can be quite helpful in terms of understanding those factors. And I've plotted within the review some of the factors that we now know were there. Many of those you've identified within the chat room. So thanks for that. So we've got this history of alcohol and substance misuse. What we don't know whether he was currently using, but his mum said that she was worried he was using it. His acute illness, his recent admission, demographics has been linked in, noted in the chat room there. His living conditions, social isolation, family dynamics. It was quite an intense close family dynamic with his mum. Lack of structure, occupation, and then the illness factors surrounding his schizophrenia, disengagement from services. His some history of suicidal ideation. His family history of suicide, we think. Loss and bereavement in terms of separation, the migration, his history of suicidal ideation, and importantly, visiting the location of high risk for suicide. So at the beginning of this presentation, I talked about ensuring that we don't have this hindsight bias and this very old model, because as those of you who know me know I am very old, but anyway, I quite like this Johari's window model of understanding what was known about risks. So looking at this, there's different quadrants, and the white quadrant there, the open quadrant, is understanding what everybody knew about risks. So the risks that everybody knew, what was written in Teo's risk assessment plan, what was known to his mum, what was known by Teo, what was open, what everybody knew about the risks that were there. But within that, we've got in the pink quadrant on the bottom left, we've got those hidden factors that is known to self. So was known to Teo, but may not be known to others. So wasn't known to Teo's mum, might not be known to services. So the things that where he was being more guarded and what he was sharing, maybe thinking about what was actually in his thoughts. So although he was saying, no, I haven't got any suicidal ideas, was that actually the case? Was he using alcohol? Was he taking his medication? All those hidden factors. The unknown factors, which was not known to self and not known to others. So that might be Teo's, where he may not be aware of how much his thinking was being affected by potentially psychosis or the influence of drugs, those kind of things which were hidden and were not known. and the not known to self or others, so the things that were kind of blind to everybody that nobody had any information about. And one of the tasks for us in working with any area of safeguarding, but also working with people in public services generally, is about how we try and open up all those different quadrants to try and share the information which is known, draw out the information which is hidden or is unknown, to bring all that out into visibility, so that helps us to have a better understanding of risk assessment and be able to make more robust risk management plans. So it's our second and last attempt at moving you back into your rooms. we're just going to do that again and give you another 10 minutes just to think about those 3 episodes of care, really. So thoughts on Teo's and his mum's experience, thinking about what was good practice. So if you were me and you'd been tasked with writing this review, what are the things that are jumping out for you in terms of the lessons that were identified, what was good practice, what do you think you would want to know a bit more about, and what do you think needs to change as a result? So what was good practice, what was problematic, and what were the barriers to effective care? So that's your task for the next 10 minutes. And as before, you will be brought back. So we'll bring you back just before 5 past. Thank you.
I think with A, there was the knowledge, wasn't there, that
We're back.
Hello, everybody's whisked back in. Fabulous. Okay. Hopefully that gave you all a bit of time to kind of reflect on what you saw was the kind of key aspects of learning. I'm going to flick open the chat room as well. It'd be really nice if we could just get a kind of summary from each of the groups, not a great detail, but either by sticking your hand up, somebody from the group, or by adding any comments into the chat room, what your key observations were really in terms of what you saw as the key learning points, what was problematic, what were the barriers to effective practice, and what was good practice. Anybody want to kick off for us there? So thanks, Jasmine. A lot of time delays in relaying information. Absolutely. We saw. Oh, what am I echoing now? We saw quite a few periods where there was delays in information getting through, delays in the discharge summary being sent out, delays or assumptions being made about people reading information that had just been uploaded onto the system, which without anybody really looking at it or really considering what that meant. So yeah, absolutely. What are the other points?
It's Diana.
Hi, Diana.
Hello, long time.
Nice to hear. Nice to hear from you.
I mean, I just wondered why Mum wasn't sent a copy of the discharge summary as a main carer, no carers assessment. What was the contingency plan? And also my colleague, there was only 2 of us speaking in our room. We wondered why Mum was texting the care coordinator, having been informed she was away for a week. So was there a language barrier, a misunderstanding? Yeah. I don't know. We don't know because we don't know the details. But
so you're absolutely right to raise those things. So Mum was sent a copy of the discharge plan, but I think we all question just how accessible it was to Mum. Somebody's put in there around, is there a language barrier for Mum? There were certainly, English was not her first language. She sometimes declined the offer of using an interpreter or translator, but they weren't necessarily always available for her. But sometimes it was more subtle than just understanding the language. It was the kind of terminology used. And actually, for any carer, navigating their way around our system is really complicated, isn't it? Never mind if English is your second language. So those things absolutely came up. And I agree with you, Diana. There was certainly learning around understanding the needs of carer. We couldn't find any evidence that she had ever been offered a carer's assessment, and yet she was a kind of key person for Teo. So that's absolutely right. She she was given the different contact points by the care coordinator of who to contact when she was away. We're not clear how well she assimilated that information. And again, it's sometimes the appearance of people understanding information, but it's kind of checking out and really being sure about that. So absolutely. I'm just looking, change in GP from Abby, was this required? Again, Abby, that's a really good point to raise, and we raised it in the review. So one of the issues for St Matthew's was rightly, they wanted to make sure that people who were inpatient in their service had their physical health needs considered. And we know that from research that very sadly, often physical health needs are not given enough attention for people with mental health needs. But TEO was only on a section 2, which meant it was intended to be a short-term assessment. His own GP was very much within the area. He was within the geographic area. So we questioned the blanket approach of appointing a new GP when actually for TEO that wasn't needed. And St Matthew's absolutely identified that learning, and they've subsequently changed that practice. But yeah, you're right. That change in the GP, and importantly, the delay in providing the GP the necessary information to adequately respond to TEO at the point of discharge, even though, you know, we were only talking 2 or 3 days, but in this case, those 2 or 3 days was really important. So thank you for that. Kim has posted resource issues when in A&E. The member of staff did not ask why he was on a train line. But was it busy A&E? Did the person use medical models with just accepting his saying he was okay? I think those are all very valid points. We absolutely acknowledged the context at that time, that it was likely that A&E was very busy at that time. The Kettering author of that part of that provided the information couldn't identify any particular additional stresses for ED at that time. But also we need to recognise it's not just on that day. You know, staff were knackered. They've been working with COVID for many months, so we've got that kind of long-term build-up period. But absolutely, some of the key points of learning, I think, is about that slightly hackney phrase, but it is relevant, of professional curiosity, being professionally curious, and recognising the need to ask that extra question. Does what somebody's saying match with what the context around their behaviours, what their demeanour is, what the information that you're being provided, does that match with what the person's saying? If there's a mismatch there, we need to be professionally curious. We need to ask that next question and not just accept on the surface what somebody's saying, perhaps. Anything else that any of the groups were reflecting on in their discussion? Okay, thank you. That's really helpful stuff that's come through that. What I'd like to suggest now is that you take some downtime from your screens. It's 15:12 at the moment, so what we're going to do is move to coffee. And if I can ask everybody to be back by 3:20 sharp, ready to go. And from that point, what I'll do is I'll talk through what the findings were from the review, what the recommendations were, and some of the key messages before we end. We will end by 4, but if everyone can be back for 20 past, please, I'd be grateful. Thank you. Nice to see you, Jane.
Yeah, and you.
All
I
right,
had no idea you were involved in this, so nice surprise.
I'm hoping everybody is back together. You've had a chance to have a quick comfort break and grab a coffee. So we're just going to do the final session for this learning event, where I'm going to talk through some of the findings. Share my screen again. Can somebody just flag that you're seeing that okay?
Yeah, we've got the coffee break slide up at the moment.
Excellent, thank you. Okay, so I'm just looking in the chat room, and Carlos and Sarah have said, why send the PPN to social care? It's a good question. I think this was a standard notification that the police had sent to social care, which is part of just them alerting the system, really, that something's come to their attention. It wasn't sent in as a safeguarding alert per se, but it was just about sharing that information. I don't know if anybody else wants to comment on that or have a better explanation than me for that. Okay, so I'm just going to move on to the findings now. So the first thing in terms of identifying some good practice that we found in the review was many of the National Confidential Inquiry into suicide and homicide, which at that point, Safer Standards, it's now called NCISS, they were met. So Theo was admitted to home locally, and for many of you, you'll know that sometimes that's really difficult. Sometimes, sadly, people are placed many miles away from home in terms of where they're receiving their inpatient care. The Safer Wards guidance was followed in terms of the levels of observation were appropriate for Theo's needs at that time, testing him for substance misuse, the risk assessment at the point of admission and during the admission, and the use of leave. So Theo was, there was a constant review of how his recovery was progressing, and trying to keep him connected by his community, to his community, and using periods of leave as appropriate. They did consult with Mum as his primary carer. There was a discharge in place, and it was communicated to Theo, as I mentioned earlier, and to Mum and to community services. There was a follow-up in the community, and that was within 72 hours. That's the recommended time, but actually he was followed up earlier than that, it was 48 hours, that being the higher risk period. There was also continuity of staffing, so Theo had the same care coordinator throughout that period. We also identified that there was effective transfer of care between the joint working with the early intervention service. This was in the period leading up to Theo's admission. So that joint visit where they'd involved Theo's previous care coordinator with his current care coordinator was seen as good practice, because this previous care coordinator understood him well. They'd seen him when he was unwell in previous times, and that was good to join that up with his current care coordinator. In the period prior to his admission, there was also good communication between the approved mental health professional service, the ambulance, and the police in that covering that period while they were trying to get the doctors together to go out with the AMP service to go and do that assessment. And with Theo's mum, so although Theo's mum was really worried and it was difficult for her, she was quite anxious, understandably, given his mental health at that time. But there was good communication maintained with Theo's mum whilst the delay in getting that period, that assessment underway. The other clear point of good practice was the vigilance and the responsiveness by the train driver when they found Theo next to the train line the week before he died, and also in terms of the British Transport Police realising that this was a concerning sign and matching that up with the information that they could glean that he did have this diagnosis of schizophrenia and had had a recent admission to hospital. So moving on to learning points now, and these are kind of grouped under different headings. So the first being risk assessments, as you can see there. So really this is the learning about drawing together those different areas of communication. So Theo did have multiple risk factors for suicide, and there is a need to draw those together. So be very explicit in terms of identifying those different illness factors, the psychological social factors, alongside those factors relating to time and place, and try and bring that together and make it into a dynamic risk assessment which is updated. The information about the losses and bereavements and the family suicide, including anniversaries, those weren't featured within his records. And it may have been that there was some question and there was some doubt about the how his father had died. But in Teo's mind, he had died through suicide, and it was really important to capture that information and feed that into the risk assessment. That was talked about during the hospital, but it didn't then flow through into his discharge summary. So the discharge summary mentioned the circumstances of admission, but there wasn't a robust risk assessment, risk management plan that flowed with that. So it does need to be personalised. Agencies providing frontline emergency care do need to note the significance of a person being found at places of high risk, and really be able to demonstrate that professional curiosity, the vigilance to other risk factors. So what we talked about when we were going through that episode of care, of saying, actually, although Teo was saying, no, I haven't got any ideas of suicide, did that really match with the context of where he was found, what was known about his recent behaviours? And bringing that all together should have led to more questions, and importantly, referring him on to other services. Teo was saying, I don't really want to see mental health liaison service, but actually the member of staff involved should have raised that with the mental health liaison team, and that process in itself would have brought more information to the fore, so they'd have been able to look in the records, look at Teo's history, and then make more persuasive follow-up for Teo. So it's about facilitating an open gateway to specialist assessment. So really recognising that kind of key function that members of staff in ED or police out on the streets, where they're coming together and seeing people in those high risk factors, they are that gateway to other services, and opening that gateway to more specialist assessment. So learning points relating to communication and coordination of care, they're always there in every review, aren't they? And this one's no exception. So there was, I think, an over-reliance on the bed manager rather than the care coordinator. So the bed manager did need to have that overview of looking at, you know, where the beds were coming free, where there was potential for people to be discharged, so they had that overview. But actually the direct contact with Teo, their care coordinator needed to take a continued lead with that, and to be able to link that information back to Teo's mum and keep that communication going. The blanket procedure that St Matthew's had of registering every patient with a new GP, it was blanket, it wasn't appropriate in this circumstance, and it did mean we lost that continuity of care in that crucial post-discharge period. There was not robust processes in place to respond during the care coordinator's leave. So the care coordinator had told mum that they were on leave. They had told UCAT that they were going on leave, but clearly that information was lost in translation somewhere along the way. So there needed to be much tighter resilience around cover when that care coordinator was on leave. Communication between some agencies following Teo being found near a train line was not effective. So the communication, both in terms of the police talking to the member of staff at AD and how that information was relayed and recorded, it wasn't actually recorded, but then also the follow-up to the notifications. So the notification where the British Transport Police sent notification to the GP and to NCC at that time, how that was all brought through, and actually not making assumptions about who was reading the records. Involvement of carers. So Teo's mum was a mainstay in his care and treatment, as somebody's raised in the chat room, and there wasn't any evidence of considering a referral for a carers assessment. Teo's mum was not well informed about the crisis and contingency plan in a way that she could process and make use of. So, you know, we expect people to understand how our very complicated systems work. And Teo's mum just simply wasn't able to do that, as well as managing her anxiety and the worries about Teo at that time. The Mental Health Act also has provision for a nearest relative having the right to request an assessment of their relative. So nearest relative is a very specific role under the Mental Health Act, and in this case Teo's mum was his nearest relative. She had the right to request he be assessed under the Mental Health Act. She wasn't aware of that right, and nobody told her of that right. So we need to make sure that people are enabled and empowered by understanding their rights. And Teo's mum's view was that she wasn't sufficiently involved during Teo's inpatient stay, so she felt she needed better communication during that period. So I'm going to lead us through to the conclusion before I go on to the recommendations and key messages from the review there. So this is a very text-heavy slide, so sorry, I will read it out. Teo's suicide was a tragedy. Reducing risks of suicide for people with schizophrenia is complex and made more challenging during the COVID pandemic. Teo's mum was in a key position to understand his mental health, and she played an essential role in his care. Teo's mum believes that Teo was let down by services. Learning from her perspective has highlighted the importance of listening to and involving families, as well as the need to support carers. Despite the sad outcome, there were many aspects of Teo's care that did follow clinical guidance and many examples of good practice. However, the review also highlighted areas of learning. The risk assessment needs to be structured and dynamic process that's shared with others. There was a need to improve the formulation of risk factors associated with suicide. There were missed opportunities to be professionally curious about concerning behaviours, to identify warning signs for suicide, and to trigger further assessment. The review highlighted the importance of communication between all parties to ensure effective coordination of care, and this is particularly important in the higher risk period following discharge. Ultimately, it's not possible to say whether Teo's death could have been averted. Sadly, there remain unanswered questions. We don't know whether Teo had pre-planned his death or whether his suicide was an impulsive action. We don't know whether he was experiencing psychotic symptoms on the day he died or whether he'd been using cannabis. We also don't know whether Teo would have disclosed this information had he been assessed by mental health specialists in the days leading up to his death. So risks of suicide cannot be eliminated, but they can often be reduced. Learning from Teo's death needs to be used to reduce the risk of suicide for others, and that's the aim of the recommendations from the review. So I'm just going to move on to those recommendations. So the first recommendation was for NHFT and St Matthew's to use the learning from this review to develop their risk assessment and safety frameworks. So NHFT, their suicide prevention lead, was already engaged in a piece of work to review their risk quality standards, their risk framework. So I wanted the learning from this review to feed into that, and particularly to be able to flag some of those kind of indicators and the wide-ranging nature of those indicators into that piece of work. The second recommendation was relating to carers and support for carers. So NHFT and St Matthew's to provide assurance to the board of systems to identify and support carers, including referral for carers assessments. So really to do that piece of internal quality assurance work, to look at how they were flagging needs for carers and making sure that they were being offered carers assessments. Agencies providing frontline responses to carers in crisis need to be able to inform nearest relatives of their rights to request a mental health fact assessment. So again, that's really thinking about what are all the areas where carers who are in crisis might contact that agency and saying, look, I'm really worried, I need some support. And for those agencies to be able to be proactive with the message about what the rights are of nearest relative, including rights to request assessment under the Mental Health Act. And recommendation 3 is for NHFT to develop their standards for the care coordinators in reach during periods of admission. So recognising that services are very much under stress at the moment, I do recognise that, but we need the NHFT to really think what's the minimum expectation that they should be able to expect of care coordinators to keep that contact with service users, with patients during that period of inpatient care. And also that NHFT need to assure the resilience of their systems to cover when people are on leave. So really look at, you know, what messages are people leaving on their phones, what's the cover for arrangements, who's checking the records when GPs are putting notes directly into the patient's records, how is that being flagged in the care coordinator's absence, all those kinds of factors. And what should be on the screen is recommendation 4, it's up there's 3 again. NHFT, St Matthews and KGH to use the learning within training and development in assessing management of suicide risk. So really using the learning from the review when they're doing internal training and just enabling staff to think around their suicide awareness and thinking about the factors that were relevant within this review. So I'm just going to pause again for a minute, just check if there's anything anybody wants to add or anything in the chat room that people want to flag before I go on to key messages. Okay, I'm just going to move on to, I'll keep a weather eye on the chat room in case anyone's got anything they want to add, but I'll move on to key messages. So as you can see on the screen, there's work to open up information and understanding about risks between practitioners, service users and carers. So that's if you remember the Joe Harry's window slide about opening up those 4 quadrants. So recognising that you are only ever seeing part of the picture and your role is about trying to open up what knowledge is held perhaps by people like the carer, by the service user, the adult themselves and anybody else in the system. How do you bring all that together to try and open up that picture of risk? You know, involve others. Remember that carers will have a unique understanding of that cared for person. So again, be attuned, you know, remembering Teo's mum saying he was different that day. There was something different about the things he was saying, the way he was acting. I'm worried about him. You know, how do we enable carers to share that sort of information with us, and how much do we feed that into our risk assessment? Ensure there are resilient arrangements within services to act on concerns in the absence of care coordinators or the key worker. Asking questions about suicidal thoughts is important, and I do want to emphasise that. You know, we know that sometimes people find it really difficult to talk to people that they're worried about, ask the question about, have you thought about ending your lives? And we know that that's really important to give people the opportunity to talk about that if it has been in their mind. So it is important to ask the question about whether somebody feels like harming themselves or has contemplated suicide. But that's not enough. We also need people to be vigilant to other factors that increase suicide risk. So think about the history, wider circumstances and the behaviours, what is said as well as what is not said. Think about higher risk periods such as point of discharge and anniversaries of death. Remember that visiting locations of high risk of suicide may be part of contemplation and planning for suicide. So just be very vigilant and mindful for that. Practitioners in emergency services are often the first point of contact for people in mental health crisis, and they play an enormously important role in the gateway to access more specialist care. So be professionally curious where behaviours raise concern, access additional expertise and share information. Carers may often need support within their role and to navigate the systems, so carers' assessments are key to this. And carers also need information about their rights and information to be able to exercise those rights. So I'm just looking in the chat room and thank you, Sarah. Care coordinators are a little out of date. The long-term plan, yeah, the phrase now is key workers. I've used the term care coordinator because that was what was known in the review, and care coordinators is still the term that many use, but absolutely the term in the long-term plan is using key worker as a phrase. Thanks, Sarah. Jane Shears, I wonder if there's recommendations for the police possibly to consider their powers under section 136. That didn't come up in this review, Jane. There wasn't actually, section 136 is the powers of police to take a person to a place of safety for the purposes of an assessment under the Mental Health Act. That actually wasn't relevant in the circumstances of this review. So the general point for the police was about vigilance as people managing people in crisis, but section 136 wasn't relevant in this review. And Abby, I wonder if Mum even knew that she could call the police, especially that morning when he was so different. I think Mum had actually contacted the police previously, so I think she would have known that, but that wasn't the route she chose in this particular circumstance. And Philip Britton, in my experience, risk assessments used in health are not great. Often the risk 3 is not completed, and when it is, it's quite poor document or format covering those in the community and in local mental health units. Social care don't have a good assessment either, just a free writing box in Eclipse. Both these make it harder to share risk effectively. These assessments, when done, are not always shared effectively. Yeah, thanks for that, Philip. I think that is hopefully part of what the review of the quality suicide standards should be looking at in terms of the use of risk assessment frameworks as well. But yeah, I can't comment specifically on Northamptonshire's ones, but that is a common finding in terms of how robust risk assessments are. And Abby, also our family members now involved in safety planning for people, as family members need to know what they can request a mental health assessment and escalate concerns. Absolutely, I absolutely agree with that. So, any final thoughts and reflections before we move towards closure? Is there anything that anyone else wants to add in terms of the chat room? Or raise your hand if you want to make a comment. Just seen a comment in from Kim. Philip, there's a new risk assessment form in WNC. Thank you for that. And if everybody else is, and it's not just open text in Eclipse. Okay. So there's some good, helpful information coming in there.